For many years before the arrival of the nighttime instruments, stainless steel hand instruments had design restrictions due to the manufacturing process that restrict creativeness in terms of variations in instrumentation techniques. I will present an instrumentation technique that is based on the real morphology of the canal and file cutting enlargement and space control. What we want is to avoid the excessive engagement of the instrument against the canal walls. It is called the low engagement technique. Let's take a look. Recent studies based on computer tomography images have shown exactly what are the dimensions of different types of canals with an impressive degree of detail. Furthermore, it's not an invasive method, doesn't need to cut the tooth to study it, keeping its anatomical faces intact. The principle of low engagement technique is to use instruments with different tapers but with the same tip diameter to achieve enlargement without forcing the weakest part of the instrument, which is its last millimeters. One of the features that we want in instrumentation is precisely the smooth increase of the diameter of the canal in sequence without forcing the instrument during the cutting and enlargement, respecting the maximum limit of 30% of the area increase after the instrument's action. Another important detail is to keep the last millimeters of the instrument as little engaged as possible, leading to a smooth cut with a final area after cutting always around 20% more than the original area. Using graphics, numbers, and colors, I will explain the instrumentation without exceeding the limit of 30% of enlargement based on morphology and instruments diameters and tapers. At this point in the graph, we can see the original root canal dimensions in the curvature and apical areas. It is recognized that the canal morphology does not have a perfect taper shape, and the curvature area has a constriction in one of the dimensions greater than the other, leading to flattening of these 2 to 3 millimeters extension area. After the curvature, the canal has a tendency to return to be less oval and more rounded. In this way, the first instrument to be used must be of greater taper but with a tip diameter compatible with the diameter of the beginning of the curvature, without exceeding the cutting limit established of 30% of the original area in the last millimeters of the instrument. The numbers inside the arrows are the dimension after cutting, following of course the dimensions of the instrument. In this case, it is a 2506, meaning the tip is 0.25 millimeters and the taper 0.06 gives more 0.06 millimeters each millimeter from the tip. In this example of the mesial root of the lower molar, mesial buccal, or mesiolingual canal, the first instrument will be a 2506. Because it is a curved canal, our preference should be a heat-treated nighttime file like Medidenta's M-File Gold because its flexibility and higher resistance to cyclic fatigue. This instrument should work limited by the position of the beginning of the curvature. A pre-enlargement will be carried out, freeing the axis of the other instruments that will turn in sequence, leaving at least 2/3 of the extension of the canal already instrumented. In the sequence, we will determine the working length with a 15 stainless steel instrument depending on the original diameter of the canal. Determine the working length using an apex locator, and once the position of the foramen has been determined, always return with this instrument at each file change to maintain patency. At this point, you can work with the K file until it's loose in the canal, or even use a 30-30 oscillatory contra angle to open a space for the next instrument in the sequence. The diameters of the instrument 1502 are represented in the center of the arrow figure. The color of the arrow means how much this instrument has enlarged the canal based on 3 groups. Green, final enlargement less than 20% more than the original canal area. Orange, final enlargement between 20 to 30%, and red, final enlargement more than 30%. The little percentage number is the exactly enhanced value after instrumentation. The main goal is to avoid the red area of action, meaning working in a range from 20 to 30% amplitude after cutting. The entire concept of LET is to avoid the red area, especially if it is concentrated in the final millimeters of the file. In a curved and narrow canals, such as calcified canals of upper molars MB2 for example, the use of two instruments, a 15 and a 2004, for a smoother progression is indicated. However, in most cases, the progression from the first use of 2506 can be made directly to a 2504 instrument. The way in which we recognize the need of the glide path is quite simple. Try to place the instrument 2504 in the working length, and if you feel a lot of resistance, remove the instrument and use the 1504 and the 2004 before the next progression to the 2504. After the 2504 action, now it's time to come back with the 2506, trying to reach the working length. To obtain a good space for irrigation and make your alteration easier, a 3504 should be used as a final file. Take a look on the graph and observe that there are a few red areas, and all of them are not in the final 3 millimeters of the file, the weakest part of the file. It is possible to work intelligently in safety even in this example that resembles a curved and narrow canal. In the next segment of root tip, I will show the LET instrumentation technique for the three main different groups of anatomy: curved and narrow, curved, and straight canals. I hope that you enjoy our root tip today, and I really hope to see you in our next root tip. If you want to ask a question, just send an email to the address that you are seeing on the screen, and I will respond here in our root tip by Medidenta. Thanks for joining us, and I hope to see you soon.